Hi, everyone. My name is Jean Marie Bradford. I'm the director of the Office of Equity and Diversity and Inclusion here in our department. Today's Grand Rounds is part of an Addressing Structural Racism series that our office coordinates with the Grand Rounds Committee. And we have, thank you for joining us here. We have one departmental announcement that I'll make before I have the great pleasure of introducing our fantastic speaker today. So join me in congratulating Aaron Slan, PGY4, on being selected the VPNS class of 2024 by the VPNS class of 2024 as one of this year's 6 outstanding residents for his qualities as teacher and role model. Nominations were provided by students in the class of 2023 who were enrolled in clinical clerkships throughout the year and encountered house staff at all hospitals where clerkships were taught. This is really an extraordinary achievement, and I just wish you a really warm congratulations, Aaron. Well-deserved on this well-deserved honor. So congratulations. It's now my great pleasure to introduce today's Grand Round speaker. Our office has been really interested in having her come back for Grand Rounds. She spoke when we were a committee of diversity and inclusion several years ago, and really excited to have her come back for the Grand Rounds format. Dr. Helena Hansen is a MD, PhD, psychiatrist, anthropologist, professor of psychiatry, and co-chair for the research theme in translational social science and health equity, as well as the associate director for the Center of Social Medicine at UCLA's David Geffen School of Medicine. She's published widely in clinical and social science journals, ranging from JAMA to New England Journal of Medicine to Social Science and Medicine and Medical Anthropology, on faith, healing of addiction in Puerto Rico, psychiatric disability under welfare reform, opioids and race, ethnic marketing of pharmaceuticals, and structural competency. Her first book, Addicted to Christ, Remaking Men in Puerto Rican Pentecostal Drug Ministries, was published in 2018. And her second book, Structural Competency in Medicine and Mental Health, a case-based approach to treating the social determinants of health, with co-editor Jonathan Metzl, was published in 2019. And her third book, Whiteout, How Racial Capitalism Changed the Color of Heroin in America, is forthcoming. She has received major funding from NIDA, the Mellon Foundation, the Robert Wood Johnson Foundation, and Open Society Foundation, and was recently elected to the National Academy of Medicine in 2021. It is with my greatest pleasure that I welcome you, Dr. Hansen.
Thank you so much, Dr. Bradford. It's quite an honor to be here. And let me see if my slides are showing up properly. Do you see them? Yes. Okay, terrific. So I want to start my story with something that has preoccupied me for the past decade or so, that really had its origins in my time at Columbia. The most recent term that I had at Columbia was as a postdoctoral fellow in the Robert Wood Johnson Health and Society Scholars Program. At the time, I was also doing an addiction psychiatry fellowship, and I was tracking the story of the evolving opioid crisis, with which we're all now intimately familiar. And I want to start with this slide, which was actually, it's a graph that was created by a graduate student that I'm working with, Joe Friedman, based on CDC data. What it tells is the story of the opioid crisis in 3 acts, right? So look at 1999. These are overdose deaths by race and ethnicity in the United States. And in 1999, overdose deaths were actually about the same across racial groups in the US. And then between 2001 and 2017, you see a pattern that's all too familiar to us who've been following the story in US media, largely seen as a white crisis. And then at the end, you see here by 2019, going into 2020, by 2020, the opioid crisis is actually reversed in that, or the overdose crisis, in that the group with the 2 groups with the highest rates of overdose in 2020 at the onset of COVID were Native American and Black Americans. So this is a story that has its origins in structural racism, structural drivers of racial inequalities. And I'll try to very quickly tell that story, which comes from my research on the race of the opioid crisis, which I detail in my forthcoming book on the topic, as a way of just centering my work in introducing concepts of structure into clinical practice. So understanding social structures as the model that best explains the inequalities that we see now. This is the version of the opioid and overdose crisis that has gotten the most media coverage over the past 2 decades. The perception of overdose as a white American problem is something that has really driven the response, the American response, both in public policy and in medicine. This is an image that conveys one of the major structural drivers of the racial identity of the opioid crisis in the early 2000s, the very aggressive marketing of newly patented and dangerous opioids, prescription opioids, to largely white and insured clientele.
Dr. Hansen, can I interject a question?
Sure.
The Deaton paper, while it includes certainly the contribution of the opioid crisis and overdose, I think it also sort of signaled the fact that after like a century-long increase in longevity, we were now seeing reductions in longevity, which signaled sort of a broader problem in terms of whatever factors are contributing to it, where it's a moral or spiritual disaffection, or whether it's individual types of contributors. So I just didn't want to. I wanted to ask you that it's not being driven solely by the opioid crisis. It's a combination of factors, and the significance has to do with longevity as well.
Dr. Liebman, thank you for that question. I'm just going to briefly say that the deaths of despair hypothesis that Case and Deaton have put forth around decrease in life expectancy among white Americans over the past 2 decades is a rich topic that has a lot to do with my story of race in the opioid crisis. I don't have time to do it justice, but drug overdose was actually the major driver of the decline in life expectancy, followed by suicide and liver disease, largely related to drug use, cirrhosis. So while I don't have time to do it justice, maybe we can bookmark that for the discussion at the end.
Sure.
Appropriate?
You're the expert.
I'm a cultural anthropologist. And so what I'm telling now is a story of a cultural history of the opioid crisis, as well as the social structural drivers behind the epidemiological patterns. So this article had tremendous cultural impact. It launched a whole discourse about the endangered white American. What is going on that white Americans would be losing this much life expectancy when other racial ethnic groups were not losing life expectancy, except for Native Americans in that time period. And so one of the major explanatory factors here is prescription opioids. That was one of the major developments in that time period, leading to that excess in overdose deaths. And then our public policy response has been very much shaped by the perception that this was a white crisis, a white overdose and opioid crisis. So one of the responses actually was the introduction of buprenorphine and the mainstreaming of addiction medicine into clinical care. And one of the things that I want to highlight about this slide from the first nationally representative sample or study of buprenorphine, comparing it to methadone, the demographics of methadone patients, is this racial difference that buprenorphine patients were much more likely to be white and actually have markers of middle-class status, such as some college education. So I just want to highlight, this is the patient population that received buprenorphine, for example, as an intervention for its opioid use disorder, very different. And this continues than the patient population that received methadone, for instance. this continues. So this is an article from 2019 JAMA Psychiatry highlighting that white Americans diagnosed with opioid use disorder are 3 to 4 times as likely as Black Americans with the same diagnosis to get buprenorphine treatment, now considered gold standard, and that the payment methods, this is also a story of social class, the payment methods, most common payment, out of pocket, cash for very expensive medication, second most common, private insurance, and then much lower on the list, public insurance such as Medicaid. So I just want to point out that narcotics in the US have been quite racialized from the beginning. So I'm just going to show you a few images from turn of the century prohibitionist campaigns. So it was really the racial image of narcotics that led to drug policy change. This is an image of Chinese opium dens in the early 1900s. And this is an image from 1914 New York Times, cocaine-crazed Negroes in the American South who were attacking their supervisors due to cocaine frenzy. And this is Mexican marijuana madness. These are the images that built public support for prohibitionist drug policies to create a whole category of illegal drugs and illegal drug markets. But at the very same time, there was a legal protected market for middle-class white narcotics users. So these are images from post-war barbiturate and later benzodiazepine ads. Okay, and they were targeting middle-class white, often housewives, often women. And the untold story is that these ads were contemporaneous with an overdose crisis of proportions that we are seeing today. So there was definitely an opioid crisis among the users of barbiturates and benzodiazepines that were responding to this aggressive marketing. But they were using these medications within a protected medical space. So we've long had these two tracks of illegal narcotics and legal narcotics that create the patterns that we're seeing even today. This is an image from the launch of the war on drugs in 1971. It has a great deal to do with the racial identity of methadone as a treatment for opioid use disorder. So methadone introduced under the war on drugs policies as one of the major weapons in Nixon's war on drugs, and largely in response to the image of heroin addicted Black and brown inner city residents at a time where race riots were raging and there was white flight from American inner cities. Civil rights activism and Black power movements were often equated in the white mainstream media with heroin addiction, somehow related to heroin. So methadone was introduced with that racial imagery targeting Black and brown inner city residents, as well as returning Vietnam veterans. If we fast forward to 2002, a very different kind of response to the evolving, largely middle class and also working class white opioid epidemic. So buprenorphine was introduced and reversed through changes in federal regulation, reversed 80 years of prohibition of private doctor maintenance of opioid dependent people on opioid treatment. And this was accompanied with marketing of buprenorphine as a treatment for opioid use disorder that reversed a lot of the imagery and stereotypes around who is addicted to opioids. So this is a public service announcement from a website that's sponsored by the manufacturer of buprenorphine. And Mike is sitting in his Ohio diner talking about having been rescued by buprenorphine treatment and a buprenorphine doctor, and being able to return to coaching his son's baseball team and singing his church choir after buprenorphine rescued him from a prescription opioid habit. So this is a very, very different image of who is addicted than we've had over the past century of anti-narcotic drug policies. So what I want to do is very quickly run through from my research on the racial identity of the opioid crisis, some of the structures that created the white image and the response, the public policy response and medical response to opioid use disorder. One is actually addiction neuroscience. So the whiteness of the opioid crisis really evolved around the time of the decade of the brain, locating addiction and many other problems, but really highlighting addiction in the brain. And what this did was it took a problem that had long been associated with Black and brown crime and located it in molecules, and in many ways paved the way for a different association with a different racial association of addiction and narcotics. It also opened up the opportunity for OxyContin and sister products, because they were sold based on a technological safeguard. You know, they were sold as a smart drug that had solved the problem of addiction through technological means. It opened up the possibility by disassociating addiction from the body and the social environment of the addicted person. It opened up the possibility for our belief in a technological solution to the problem of addiction. So very well-intended addiction researchers who wanted to democratize addiction, the problem of addiction, and destigmatize addiction by redefining it as a brain disease, actually, in the end, by taking the social context of addiction and drug use out of the picture, opened up the possibility for much more directed narcotics marketers to get around regulations by marketing a technologically based solution to the problem of addiction. So that's what this imagery that came out in the 90s and was really pervasive in clinical journals, centering the molecular nature of addiction. That is how that imagery actually helped when it came to the introduction of new biotechnologies to foster a belief in molecular solutions to problems that had been associated with social conditions and also with Black and brown race. So OxyContin in this background was introduced as, because of its sustained release capsule technology, something that had solved the problem of addiction by releasing only a small amount of oxycodone at a time and not providing the rush of release of high concentration of oxycodone to the brain. And what the marketers and FDA regulators left out of the equation was the social context of its use. So of course, once OxyContin reached market, drug users that were interested in a rush quickly learned how to crush and inject or snort the contents, the oxycodone contents. So in addition, in response to the widespread overdose problem that came out of OxyContin's introduction in sister products, Suboxone, otherwise known as buprenorphine, was introduced as, again, a technological response to the problem of opioid addiction. So this was in sharp contrast to the response historically that we've had to overdose deaths in the 1970s and 1980s, from the 60s to the 80s, overdose deaths in Black and brown communities that led to, on the one hand, segregated methadone maintenance systems, and on the other hand, repressive drug policies. By the time of OxyContin and sister products and the overdose deaths that came out of that, buprenorphine was introduced as the major intervention. I want to skip forward because I want to focus on structural competency for this talk, but to finish the story of structures of the whiteness of the opioid crisis, regulation also changed in response to the racial imagery of the prescription opioid epidemic. The Drug Addiction Treatment Act of 2000, data 2000, was introduced after congressional debate. So this was an act that legalized private doctor prescribing of buprenorphine specifically for treatment of opioid use disorder. And it was introduced after congressional debates that highlighted the evolving problem of quote unquote suburban youth, of opioid use and overdose among suburban youth. And in the congressional debates, it was many many of those giving testimony highlighted over and over again that this was a problem that was inappropriate for methadone. So methadone, this was a group of patients that were not appropriate for methadone, which was better for quote unquote hardcore users, that buprenorphine and office-based private office-based treatment for addiction was needed for this new generation of suburban youth. And so this was a testimony that led to the legalization of buprenorphine as an office-based treatment, but did nothing to change the regulations that limited methadone patients to in-person daily directly observed dosing. And also the requirement for waivers for buprenorphine training, 8 hours of buprenorphine training, voluntary training on the part of prescribers, and certification, greatly limited access to patients who were in the public system, in the public sector. So buprenorphine was largely restricted to private sector patients, and by definition, middle class and largely white patients. So it did create, Data 2000, a separate treatment track for white and middle class opioid dependent people. And this is the buprenorphine prescriber locator service that SAMHSA, Substance Abuse and Mental Health Services Administration, developed in collaboration with the manufacturer of buprenorphine. And it has, according to the doctors that I've interviewed in my research, greatly limited access in the public sector to buprenorphine. Lastly, I want to end with another structure of whiteness, which is media and marketing. So the manufacturers of opioids, prescription opioids, OxyContin and sister products, focused on predominantly white populations in states like Ohio, Kentucky, West Virginia, Maine. And this led to disproportionate uptake of these prescription opioids in those areas, predominantly white areas of those states. The public perception of who was opioid addicted was greatly influenced by media coverage that in the early days of prescription opioid overdose really humanized the stories of and the stories really centered on the bodily and psychic pain and suffering of the opioid users. As prescription drug monitoring programs combined with tamper-resistant formulations of opioids channeled people who were opioid dependent away from pharmacies and doctors' prescriptions towards street supplies of opioids, the public media image of heroin also changed, the racial image of heroin. So these are images from a series of newspaper articles that were run on the evolving problem of suburban heroin use. This is a school teacher from suburban upstate New York, and this is a college athlete from Arizona. So these are just two of myriad images that actually whitened heroin use in response to the restrictions on prescription opioid access and the uptake in suburban and small town America of heroin among newly dependent people. And then here in response, this is the website of the National Alliance of Advocates for Buprenorphine Treatment, sponsored by the manufacturers of buprenorphine. And you'll see in the lower left-hand corner, patients find a buprenorphine physician. So many of you may have referred people to this. You put in your zip code, you get a printout of prescribers in your area. And these prescribers will be, by definition, largely in private practice. The incentives for buprenorphine treatment aren't there for public sector physicians. And so what I want to do is use this story of the structural racial history of the opioid crisis, which now is in its next phase of Black and Native American overdose deaths having overtaken white American deaths, largely due to the advent of fentanyl. which has, number one, penetrated into markets across the country because it's so much easier to smuggle, and particularly in small town and rural America that hadn't had heroin markets, heroin having been confined to big port cities where it's easier to smuggle. Fentanyl has made incredible inroads, but it's affected all markets across America, accelerated by COVID, including large cities where Black and Brown Americans are now exposed, disproportionately exposed, and where mass incarceration, itself a risk factor for overdose, has driven deaths among Black Americans who are disproportionately incarcerated and at high risk for overdose in the period post-release. So post-release period being a time when people who've been in jail or in prison have lower tolerance, have a lot of social instability, a lot of risk for relapse, poor access to medical care and social services. So mass incarceration itself has become a risk factor for overdose, multiplied, significantly accelerated by fentanyl. So I just want to highlight these points, that we have to understand the structural history of the racial inequalities and racial patterning of overdose by looking at how racial capital in pharma and biotech industries, such as, for example, pharmaceutical manufacturers that aggressively marketed OxyContin and sister products, they harm the health of white Americans, as well as ultimately the health of many other racial groups. Also, the magic bullet ideology that greatly accelerated the marketing of OxyContin and sister products by really putting so much into the belief that molecular technologies can get around the problem of addiction and erase kind of the messy social context of it. They reinforce structural racism that ultimately harms white Americans along with Black and Brown Americans. So I want to now segue into structural competency, which is an approach to clinical training and practice that I and colleagues are promoting, and that I want to argue for myself has great promise. I saw personally up close as a pre-medical student, and before I applied to medical school, I was working with AIDS, the AIDS Coalition, and saw that the AIDS epidemic and AIDS activism in response to AIDS in the 1980s to early 90s was a source of enormous change in the way that medicine is practiced and medical research is designed. So I was inspired by the fact that AIDS activists, those directly affected by HIV and taking care of HIV positive family members, in collaboration with doctors, nurses, other healthcare practitioners, and in collaboration with them, were able to take a problem of HIV and AIDS that had been extremely marginalized due to its association with Black and Brown race, with LGBTQ communities, and get significant federal funding, get mandates at the NIH for HIV positive people to sit on decision-making bodies that decided on research funding and appropriate research questions, the way that research should be conducted, also required community members to be involved in study design and implementation. The Ryan White Care Act, the federal funding that goes to AIDS services, requires community councils that are made up of people who are HIV positive, that include people who are HIV positive and from directly affected communities. And this has affected the kinds of services that the federal government funds, including housing as a part of HIV treatment and buddy systems, peer support. So I was inspired at the beginning of my career in medicine by AIDS activism and the power of collaborations between clinical practitioners and people from directly affected communities to make significant change at federal levels and local levels. And this is a story that this is a way of thinking about medicine that goes back, locating inequalities in health, in social conditions, and the need for clinical practitioners to act on them. So this is Rudolf Fierkel, considered the founder of modern Western pathology, but also founder of social medicine based on his work on the typhus epidemic and then Prussia, now Germany, locating it in the working conditions of working class Prussian people. And this is also an approach addressing social conditions as drivers of health inequalities that got a really big renaissance in the 1960s. So the founding of the federally qualified healthcare system, the community health system that we have in the United States, so federally funded clinics in underserved communities. This is a book, and it's accompanied by a 20-minute documentary that's on YouTube that I highly recommend, that tells the story of the founding of federally qualified healthcare systems in the Mississippi Delta. H. Jack Geiger and colleagues worked with largely African-American and unemployed former agricultural workers who were suffering very high rates of infant mortality and a whole host of other problems. They made headlines by prescribing food for malnourished children, prescription to be filled in pantries that were stocked with federal monies assigned to the FQHC, the Community Health Center, but they also were using federal money to buy land for cooperative farms for these displaced workers to grow their own food for survival. And they're also teaching night school in the clinic buildings. So allowing people to get their GEDs in a community with very low level of education. Some of the graduates went on to train in clinical professions and came back to serve the community. So I'm going to skip forward to the 1990s and a very different idea of where health inequalities come from, that came from an individualizing moment in American history where we began to think about the beliefs and behaviors of patients as responsible. So this is David Satcher's 1999 report, which made headlines with sound bites such as Black men are 4 to 6 times as likely as white men to get schizophrenia, to be diagnosed with schizophrenia. And recent Chinese immigrants, Native Americans, much more likely to commit suicide without ever having had mental health care. Without, though, an explanation for these inequalities in mental health, we were left to focus on the first word in this report after mental health: culture. So the idea that cultural differences, beliefs, and behaviors might be responsible for these inequalities. And that left out of the picture the structural drivers. So this was the concept of culture that was really prevalent in my day of 1990s medical education, that there's Black culture on one hand, white culture on the other. They don't interact, and they're responsible for health inequalities. And then this is a much more complete picture. That's consistent with my training in social sciences, that culture is quite dynamic. It shapes policies and social institutions. It's also shaped by policies and social institutions. In the US, a lot of what we see in the way of health inequalities is directly related to racial segregation by neighborhood, residential segregation in housing, and also in schools and employment. Mass incarceration is another very big structural driver of health inequalities, as I explained in my racial history of the opioid and overdose crisis. So mass incarceration being driven by drug laws that often were formed deliberately with racial targeting in mind, and racially targeted law enforcement and sentencing. So those are just some of the structural drivers that that actually fall within culture. And then there's another really big driver of the way that we practice psychiatry and medicine in the US. My racial history of the opioid crisis highlighted this, but the power of big pharma, medical insurance companies, health insurance companies, and biotech. So they are one of the largest single economic sectors in our country, and also very strong lobbies, and have a lot to do with the systems of care that we are embedded in now. Structural competency is my effort and the effort of my colleagues in this movement to introduce not only social determinants as a concept into clinical care. I think social determinants is now much more widely taught in medical school than it was when I came through. But also to teach about social structures as drivers of inequalities in health. And by social structures, I mean community organizations, health relevant sectors like schools, housing, and law enforcement, also public policies. And I like to distinguish between structural drivers and social determinants of health. So let's just take for an example, housing. At this point in time, in 2022, many of us are beginning to screen for unstable housing in our clinical care. So when we see a patient and we're doing an assessment, we will ask if that patient has stable housing, because we know that that's a very big driver of poor health outcomes, and that we should, if we can, do something about it if our patients don't have stable housing. But what we don't often do is back up to ask, why is it that in certain neighborhoods and in certain groups, we have much more prevalent unstable housing than in others? For that, we have to look at urban planning, city and state zoning laws and development plans that, for example, through urban renewal, that's one set of public policies that has serially displaced low income and Black and brown communities. And also things like in New York City, planned shrinkage, the burnout of 40% of the housing stock in the South Bronx in the 70s and 80s was directly related to the deliberate closure of fire stations in those neighborhoods in order to clear the land for developers. And then the 2008 housing bubble, and all of the people that faced foreclosure because of predatory lending that culminated in the 2008 housing crisis. So these are the kinds of structures that explain the patterning, the demographics of unstable housing. And we've just gone through a year of discussing the racial patterning of law enforcement and sentencing in the country. It's easiest to see these kinds of inequalities in international comparisons. So this is the 2014 Institute of Medicine report that had the soundbite that the US spends the most per capita on healthcare of any country in the world and gets the worst health outcomes, both mental and physical health outcomes. And their explanations were actually structural, having to do with the lack of public health law in the country and planning for public health through transportation, food access, lack of universal health coverage, just to name a couple. And this was this is a chart, a graph that is in a book called The Spirit Level by social epidemiologists Richard Wilkinson and Kate Pickett. Another international comparison. This is mental health outcomes. The same is true for physical health outcomes, that there's this linear relationship between measures of social inequality, largely having to do with how evenly income is distributed in a society, and health outcomes. So the US being the most extreme in terms of poor distribution of wealth and the worst health outcomes, mental and physical. On the other end of the extreme, countries like Japan and Germany that have better distribution of wealth and better health outcomes. One thing that we might get to in the discussion is the spirit level also points to the fact that the wealthiest people in all of those countries, if you compare them, countries like the US with poor distribution of wealth, the wealthiest quartile, life expectancy of those in the wealthiest quartile is actually lower than the life expectancy of the wealthiest people, the wealthiest quartile in more equal countries. So the soundbite is that inequalities are bad even for the health of the rich. And maybe we can get back to discussing that at the end. So I just want to signal, I think we've been through a lot of discussion in the country about different forms of racism, how racism gets under the skin, and how institutional systemic structural racism influence health. And you may have had discussions about redlining as one example, discriminatory lending when it comes to mortgages and small business loans in neighborhoods that have predominantly Black, brown, migrant, in this case of 1932, Pennsylvania, Philadelphia, neighborhoods being considered high risk for loans and ineligible for loans, and all the intergenerational impacts that has had for families' ability to weather unemployment, illness in the family, ability to send children to college, and really strong health influence. So if you take any map of redlining in US cities and look at chronic disease today, you'll see that chronic disease is concentrated in those neighborhoods that did not have access to loans. And I want to point out that today we have a crisis, particularly among all clinical practitioners, but particularly among psychiatrists, that there is a very high level of reported burnout in professional burnout in clinical care and people leaving clinical practice. And when asked about why, practitioners that are dropping out and burning out point to social drivers of their patients' health outcomes that they don't feel they have any skills or ability to address. So for our own benefit, for our own self-preservation, we have to attend to these social drivers and build skills. That's where structural competency comes in. The term structure is signaling the need to shift above the level of the individual patient, their beliefs and behaviors, and look at institutions. And so again, I want to go back to my history, my racial history of the structural drivers of the race of opioid overdose. But institutions such as clinical, educational, correctional, community conditions, neighborhood organizations, and policies that determine health. And then competency refers to our responsibility as clinical practitioners to actually act on those structural drivers of our patients' health. So practitioners bring, including psychiatrists, bring a lot to bear here in the way of symbolic capital, as well as knowledge, cultural capital, and social capital, our connections. So we've been quite absent in discussions about public policy in the past, but in partnership and absent in institutional change, but in partnership with people who have skills in policy advocacy, community organizing, we have a lot to offer. And this very briefly are the competencies that I and my colleague Jonathan Metzel have outlined that we need to recognize and be able to talk about structural drivers in our patients' presentations in the clinic, but we also need to observe and practice structural intervention in our practice. That's something that in medical schools goes against the grain. We don't have a lot of opportunities for trainees, for medical students to observe and practice structural intervention. And that's where I've been spending most of my time these past few years, working with colleagues to create those kinds of opportunities, while at the same time developing structural humility. Structural humility referring to the fact that this kind of structural change is very slow, so we have to have patience. And we also have to know that we as clinical practitioners don't have all of the expertise and knowledges needed to achieve it. So we have to work in partnership with people who do, such as community organizers, policy advocates. And this is a book that we have published with case examples from different clinical practices and medical schools across the country of how people have put structural competency into practice. I'm going to end by quickly going through a rubric that I use of different levels of structure at which we can intervene as clinical practitioners. The first level of structure is in the clinic. It's the low-hanging fruit of what we can do where we normally spend our time, in the four walls of the clinic with a patient. Electronic medical records. It's more and more common now that screens for questions about social needs of patients, such as housing, food access, legal involvement, are embedded in the electronic medical record and prompt practitioners to ask about these when they see a patient. And this has actually led to, in the research that's been done, a big uptick in referrals for social services. So just putting these questions in the electronic medical record has an impact. Then medical legal partnerships. So these are partnerships often between clinics, often teaching clinics, and pro bono lawyers or law students. And patient problems that lend themselves to legal intervention really benefit from this, where, for example, our patients in psychiatry who are often evicted by landlords in violation of the Americans with Disabilities Act, a pro bono lawyer or law student can help us pursue that in a way that we can't pursue on our own. Sometimes when patterns are detected, citywide or population-wide, these medical legal partnerships have actually led to policy change as well. I'll get to that level of intervention in a moment. To go back to that slide, social prescribing. So For example, Health Leads is an organization that works with clinicians so that clinicians can write a prescription for example, assistance with applying for Social Security disability. And volunteers or community-based organizations can then guide the patient, fill that prescription by guiding the patient through the process of applying for Social Security. Lastly, peer navigation and the use of community health workers. That's something that's catching on among us in psychiatric practice. That in itself, including people who have lived experience and who are from directly affected communities as partners on the healthcare team, that is in itself a structural intervention. Then there's the level of partnering with community organizations. So on the right-hand side, you'll see in the center of that photo under Money Breakthrough, Ayana Jordan, my colleague who is working with Black and Latinx churches to integrate substance use treatment into churches and other faith-based organizations, because Black and Brown people often have had very negative experiences in traditional biomedical clinics and will avoid treatment there. And so this is a way of opening up trusted community settings and also people as providers that are trusted and known to community members as a way of getting people into treatment. And it's also changed the nature of the treatment. So peers are integrated into this, people with lived experience who guide the program participants through getting onto medication, recovery support, and a whole host of other services. And there's an analogous set of programs among Native Americans who, as you now know, also have extremely high overdose rates to integrate medication for opioid use disorder into spiritual healing centers and practices. So it's a similar concept. And I don't have time to get into detail now, but I have, in my time at NYU, at New York University, I worked with the Brownsville Partnership, which is a homelessness prevention program located in Brownsville, Brooklyn, an area of very high rates of unstable housing, to get psychiatry residents to develop mental health interventions in community. And this has morphed into another project in Harlem, at the OMH, the state mental health clinic in Harlem, to send psychiatry residents into community-based organizations together with a peer navigator who has lived experience and is trained in mental health care provision. And they've visited a whole series of sites from faith-based organizations, harm reduction centers, cultural arts centers, community gardens that have something to offer patients in recovery. And these residents have uploaded the information into an interactive map that can be used for treatment planning. The next level of structural intervention is collaborating with other non-health sectors. So I mentioned schools, I mentioned law enforcement. Here's an image of Mindy Fullylove, who at one point was on your faculty, started off her career as a psychiatrist, but in her very eye-opening research on the impact of racial segregation in US cities as a major driver of health inequalities, she has begun to work with city planners and architects to integrate US cities. And so she's come a long way in cities like Pittsburgh, Pennsylvania, Orange, New Jersey, to redesigning cities and treating the patient of the city, the pathologies of the city, creating green spaces, taking down dividers such as highway overpasses that were placed in earlier eras to segregate cities by race and class, taking them down and opening up common spaces and lots of other interventions to integrate cities as a health intervention. So that's just one example of cross-sector collaboration. And then there's my world of drug war disparities in incarceration and also in addiction interventions and outcomes. This is an organization called From Punishment to Public Health that I have been a part of, that joins together psychiatrists and other clinical practitioners with formerly incarcerated people, public health practitioners, but also disenchanted law enforcement and corrections officials. And what they've done, they've launched a whole host of initiatives to redirect people from carceral systems, prisons and jails, to mental health treatment. because as psychiatrists, we know how many of our patients are incarcerated who actually need treatment. One of the major things they do, though, is provide training in advocacy and giving testimony to policymakers about the health impacts of laws, such as drug laws, housing laws. And so, and also training in op-ed writing. So these are ways that clinical practitioners can collaborate with others to be active in policy advocacy on behalf of patients. I'll end with this slide just as an invitation. It's a website that has training materials, videos from some of our events, and a way for you to sign on to our listserv and become a part of the network. So with that, I will open up for questions.
Thank you so much for that wonderful presentation. I am really interested. I was so happy to hear a lot of the things that you brought forward to us, and also I was also active and aware of sort of the HIV crisis and the community organizers back then too. So I was really interested to see how you brought that in as well. We have a ton of questions. One thing I'd just like to say is that, you know, the audience, there's a ton of people here. This might be a record for our grand rounds in terms of number of attendance. And one of the benefits actually of doing this remotely is that we get to have a higher actual audience. So we actually couldn't fit the number of people that are here now in our physical auditorium. So that's actually really good. So I have some questions of my own, but I'm gonna get straight to what people have been putting in first. And it looks like people have been commenting on Jack Geiger's inspiration to create centers.
So, and I'm so glad that Dr. Susser is on the line. Thank you, quite an honor. And he's absolutely right to point to the fact that what happened in the Mississippi Delta, led by H. Jack Geiger and colleagues, was actually an offshoot from an international movement. And one thing that's so fascinating, in my work in structural competency, I've been participating in global health groups that are dissatisfied with the narrow scope of current global health interventions, really want to introduce a structural lens to the inequalities that we see internationally. And it turns out there's a history of social medicine movements from many different parts of the world. So there's an Indian social medicine movement, there's a Brazilian social medicine movement, there's a South African social medicine movement that absolutely did start in the 40s and 50s with the Karks. And when they were expelled from South Africa based on their resistance to the apartheid regime, they brought a lot of their approaches here, beginning with Einstein School of Medicine and then spreading to many other centers throughout the country. So there's this very interesting international history of social medicine movements. So that's why, you know, in the title of my talk, Structural Competency Medicine for the Inequalities That Make Us Sick, originally I had used the term new medicine, but it's not new. Actually, you know, I wanted to do due diligence by at least signaling that these social medicine ideas come from many different sources over a long period of time. So this is a part of a historical arc. And we can constantly reinvent the wheel, this time in using the word of structure, you know, the terms of structure, because using the term competency, because we're in the era of competencies right now, you know, the AAMC, ACGME, keep multiplying the competencies that medical students and residents have to demonstrate before they can get they can graduate and get their licensing. And so we're tapping into that, but this is old wine in new bottles, so to speak.
Another question is about what are sort of plans or the current policies that might be able to assist with the divide among with mental health care among minorities?
Policies that can assist in the divide in mental health care. So one thing I want to do is really give credit to my colleagues who in psychiatry are making connections that we don't normally make. So we're in a field, American psychiatry, we're in a field that is still in a phase of wishful thinking. That's the way that I like to put it, that we have aspirations to become a fully biological discipline. We're still very much in the throes of brain disease models of psychiatric problems. I don't want to deny the incredible breakthroughs in neuroscience that we're tapping into as a field. But one thing we've lost sight of over the past 3 to 4 decades is the social embeddedness of the mental health problems that we're trying to treat. And we have hamstrung ourselves, not having the tools to approach them as social problems that have biological manifestations. It might make us feel better as a field to look to diabetes, asthma, and hypertension. Okay, these are in my field of addiction psychiatry. We'll often point to diabetes, asthma, and hypertension and say, you know, addiction is very much like diabetes and asthma and hypertension when it comes to treatment adherence, relapse rates, so many other factors. It behaves like a chronic medical condition that we don't even think of as a mental health problem. But anyone who's tried to treat asthma, diabetes, and hypertension knows how incredibly sensitive to the social environment those conditions are. You know, you have to address access to fresh foods. You have to address safe, walkable space so that people can be active. For asthma, you will look at urban planning and the correlation of proximity to highway overpasses and the air quality in substandard housing. And so you begin to understand that the social environment is a major driver of biological outcomes. And in our aspiration to become a brain-based discipline, what we need to remember is that the social environment has a big impact on biology, and cutting-edge neuroscience now is focused on things like neuroplasticity. You know, the way that brain development is shaped by social environment well into adulthood, focused on epigenetics, the fact that social environment has a huge impact on gene expression. Also microbiome, you know, the gut-brain relationship and the impact of microorganisms on brain development. That's cutting edge neuroscience. And in some ways, psychiatry is behind the ball in its understanding of what the brain and what biological process actually involves. Because if we understood that, we'd pay a lot more attention to social environment. That's a long-winded way of leading to my colleagues who are at the cutting edge right now of looking at, for example, the carceral system, drug law reform. These are things that have huge mental health impacts. I've already outlined the relationship to opioid overdose and overdose deaths generally from multiple substances of incarceration. So I'm in Los Angeles. Los Angeles has the largest single public provider of mental health services. And guess what that is? The jail system.
Jail.
Right. And so I want to give credit to my colleagues in psychiatry who are really at the cutting edge of working toward, as a mental health intervention, reform of drug laws, reform of the carceral system, because that's where we're going to see a big impact on mental health outcomes and on mental health care. That just as one example. But what I wanted to highlight with my talk is that structural competency is a way of thinking. It's not a single solution. It's an orientation that focuses us at other levels of intervention than we have been accustomed to or trained to use. So it's going to vary by place and by time and the type of mental health problem that you're facing. And so if someone were to give an example of a specific mental health problem in context, then we can start to track what are some of the drivers of that mental health problem. But there's a huge payoff, for example, in housing. Housing policy has a lot to do with mental health. And that's well documented. Mindy Foley-Love is one of the main contributors to that literature. So housing, the carceral system is another one. And also income inequality, right? Those charts that I showed from the spirit level, the international comparisons, that's a major driver of mental health outcomes. So that's where we should be putting much of our symbolic, social, and cultural capital to making sure that those drivers of mental health inequalities are taken care of.
Jean Marie, can I make one quick comment about this? I know we've got a lot of questions, but even though Helena, we're separated by 3,000 miles, we are in a very significant way kindred spirits, because what you're saying is something that I think is reflected and appreciated throughout our approach to mental health care. And even though there has been this movement, this oscillation from the psychodynamic to the neuroscientific biologic, psychiatry is the most pluralistic discipline in all of medicine. The points that you're making about structural competence is critical, because no matter what we do to try and be sensitive and improve the quality of care, the cultural sensitivity and competence, there are structural barriers to being able to provide it, because we don't have a healthcare system, we have a health business system. So one thing that I would sort of throw out for your comment or consideration is it's structural competence, but it's also structural policy, because we're really constrained by the policies which dictate the healthcare system that provides these structural impediments. And for that reason, apart from the three career paths of clinical service, research, and education that traditionally academic medical centers have guided people towards, health policy needs to be one of those in order to be able to change those things.
Very well said. And one of my messages, I've done a lot of talking about structural competency to medical students and residents. And some of them ask me the question, do we all have to become policy makers? Or do we have to be policy experts to practice medicine all of a sudden? And my response to that is no. There are many different ways that we as practitioners can be involved in the kind of systemic change that is really necessary to improve our patients' health. Some of us will go on to get training in public policy, and I think we need far more psychiatrists active in public policy. And some of my colleagues are doing fellowships in the White House, and are congressional aides and are learning the ins and outs of federal policy, state policy, city policy. That is incredible, and we need far more of them. But each of us can find a way to integrate a structural perspective and intervention into the work that we do. And my argument to a set of medical students that I was talking with just yesterday was that, you're going to find that if you step into the American healthcare system, you will be, by definition, put into situations where you cannot do for your patient what you know needs to be done. There's no way you can avoid it.
And that goes double for mental health care.
Yes. And so you will be on the phone trying to get authorization from an insurance company and not get it, and send a patient on with a treatment plan that is not going to serve them, possibly end in death. And that happens to those of us who are practicing clinical medicine over and over again. The statistics I reviewed about burnout and departure from clinical care, that's an acute crisis in psychiatry. I know a lot of clinics, including in New York City, that have an incredibly hard time recruiting psychiatrists to practice, especially public clinics, especially in public psychiatry. And it's because from a very young age, as medical students, we're exposed to that kind of frustration and pain of not being able to do right by our patients. We go into psychiatry to help people. Sometimes we end up actually hurting them because the systemic constraints on what we can do and how we can practice. So by definition, we're stepping into a system that is harming patients. And on some level, we have to find ways to push back against that. But it's going to take many different forms. So, I went through that rubric of levels of structure. So some people will be involved in integrating these questions of social needs into the electronic medical record. And Then once they start to identify social needs, they're also going to run up against the lack of resources, right? Who do I refer this patient to for community-based services? And from that point, then they start to look at, well, what's available in the community and what can I do to help to augment what's available in community. So I showed some images of community partnerships with community organizations. So some of us will go on to partner with schools to start early intervention, mental health intervention programs in partnership with schools and educators and families. Some of us will, as Ayana Jordan did, and I know you have Sydney Hankerson on faculty as well, reach out to faith-based organizations. So many groups actually go to clergy first. They don't come to mental health practitioners when they're in distress for many reasons. Some of those reasons have to do with what we've done wrong as psychiatrists, because people have had very negative experiences. The first encounter that many African Americans have with mental health care often is in corrections, their first, or in an ER under very difficult conditions, and they're not treated well. And so it becomes a vicious circle because people have had these very negative experiences with mental health care providers. They avoid biomedical mental health care, and they will turn to faith-based organizations or other trusted community organizations when they're in need. Those organizations sometimes are overwhelmed and can't handle what is coming to them. And that's where these partnerships play a really important role. So there are many different ways that we can be thinking and acting structurally. You don't have to become a policymaker or a White House fellow. There are many different levels. And so that's a long but still short answer to that question.
Jean Marie, you got a long queue.
There's a lot of questions, yes. And one of them is about the social prescribing in addressing inequality in healthcare, and particularly what kinds of research would you suggest in improving our structural competency through social prescribing? And any data that you'd suggest collecting or available to do so.
Yeah, so social prescribing is having its heyday right now, I think. And that's because, again, it's that low-hanging fruit of what can you start to do in the clinic itself. Social prescribing, in the example that I gave of what happened in the Mississippi Delta in the first FQHC, the leading edge of that news story in the late 60s was the prescribing of food in the clinic stock pantry for these malnourished children. So the treatment for starvation is not medicine, or it is if you consider food medicine. The treatment is food. But there's so much more to the story. And I mentioned the cooperative farm that was started on land that was purchased by the clinic. I mentioned the night school that the clinic ran out of the clinic building to educate a population that had much lower average education than high school. And we all know the strong correlation between health outcomes and level of education. The reason I mentioned those is that social prescribing on its own can't solve all of these problems. It's an important reorientation, and it introduces clinicians to the idea that so much goes on outside of the four walls of the clinic. So when you send someone back out into their community, you have to send them equipped for the things that they need for their recovery in community. And that will involve community resources, community-based resources. But you quickly run up against the lack of resources. That's the rub. And so that's where I think we as practitioners, if we begin to do social prescribing and we're really thinking structurally, we end up with partnering with agencies, non-health agencies, and with community organizations to try to, number one, strengthen the network of services that are already there and funded, because often there are in New York City, it's pretty well funded. You do have resources, but they're not well organized and people can't navigate them easily. So you might introduce peer navigators into the system, into the mix, or other ways to link together the services. but then you often are also stuck with more services need to be created. And clinical practitioners can play a really important role in that. And eventually it leads you up, you then bump up against lack of resources, including public resources, and that quickly brings you into the policy advocacy realm, standing up for housing as a part of healthcare, for example, because we know that housing is such a strong determinant of health outcomes. But again, there are a whole host of policies that are responsible for the lack of affordable housing in cities like New York and LA. And so if clinical practitioners, psychiatrists, doctors, nurses stand up as a group and say, housing is health, and we need to invest in health as we need to invest in housing as a health intervention, that changes the equation. So I think you quickly bump up against these different levels of structure.
There's also questions about the full range of the life cycle, right? So where does this apply to expectant families, also with children? And specifically, one of the questions is about inequality for development of conduct disorder in children and substance abuse and legal problems. And so thinking about those groups.
So what was the question? How to
Question is, so I'll do there. The one was just one about where does the work with expectant families fit into what you're speaking about? Like, how do you see the, structural interventions perhaps for, playing a role in expectant families or social prescribing? And the second is about the inequality for the development of conduct disorder in children and substance abuse and legal problems. And is there any change in social medicine policy that could be applied to decrease those disorders?
These are really great questions. And what they both have in common is the need to understand the structure of the family, and the life cycle in all of this. So I have a number of colleagues in this growing structural competency network who are devoted to understanding historical trauma. So, for example, I'll just name my colleague Denise Shervington, who recently arrived to Charles Drew University in Los Angeles, who came from New Orleans, where she was studying trauma, the impact of trauma, including Katrina, on families there. But in Black and brown city neighborhoods across the country, what we're often seeing is the historical outcome of serial displacement, of disinvestment from neighborhoods, unstable housing, also actually family separation, foster care placement, and the ways that Child and Family Services have approached substance use and mental health problems in Black and brown families in this country has greatly contributed to this historical trauma. Because what I see as an addiction psychiatrist is people who have gone through multiple generations of family disunion as a response to substance abuse problems. So wealthy people generally don't lose custody of their children over substance use problems. They have a lot of protections for themselves, legal protections, and they can hire babysitters, they can hire people to make up for whatever is not happening in childcare because of their substance use. Poor people, and in particular, Black and brown people, have been subject to many decades of family disunion based on mental health and substance use problems. And what that does is it sets up the younger generation to repeat the very same cycle. So those who are in foster care are very high risk for their own substance use and mental health problems and losing custody of their own children. So I just picked that out as one example of how we can understand this as a cycle, trace it to its policy and its institutional roots. For example, in Child Protective Services, there is a movement to invest in resources to preserve family unity. I'll give you a really interesting example that comes from Canada, where, in some areas they're far ahead of us. So Vancouver, Canada, which is at the leading edge of alternative responses to problem substance use. They've led harm reduction in North America. There's an organization called Atira Women's Society that began as a housing organization. It provided housing to women who were experiencing intimate partner violence, but also women who had substance use problems and unstable housing. So they provided housing that had no requirements when it came to abstinence from drugs, kind of housing first model, but for women. And they quickly learned that a big problem facing these women was loss of custody of their children, which set them up for relapse into substance use and overdose, and set their children up for future substance use problems. And many of these women were First Nations. So in Canada, the discourse is less around Black Canadians and more around Indigenous Canadians. And so many of them were First Nations and had themselves been raised in foster care, because that was a systematic practice on the part of the Canadian government over the past century to remove Native children from their families and put them in foster care. So Atira Women's Society not only bought up and developed housing for these women, but also negotiated with the local Child Protective Services agency to allow women to keep custody of their children, even if they were actively using drugs. So what they did to compensate for that was provided 24-hour, 7-day-a-week childcare, early education, early childhood education, and many other supports, educational supports, emotional supports for the children. And they have had fantastic outcomes in keeping families together and also helping women who with problem substance use to arrive to a much more stable way of life. And so I just hold that up as an alternative example. It was led by activists for women's rights, as well as nurses and other healthcare practitioners. And that's the kind of thing that we as psychiatrists could be focused on, because we see, by definition, if we're working with people with very serious mental health problems, we see a disproportionate number of people who've been through the foster care system.
There's another question just about the work with the EMR, and if you are familiar with any good products in particular, because it's been sort of scanty what's available. And so how do you see, it says, this is from Dr. Weissman, our experience in carrying out research with social determinants of health, the available social determinants in health and EHR are pretty scanty. And so what do you recommend in order to facilitate research?
So I want to turn to that question in a moment after I answered the other one that I realized I overlooked, having to do with behavioral disruptive behavior. And actually, Columbia is the home of some leading researchers documenting the fact that low-income children who are on Medicaid, and particularly Black and brown low-income children who get Social Security benefits, have foster care involvement. These are all risk factors for being placed on off-label use of antipsychotics for behavioral disorders that in many other settings might be labeled ADHD, as opposed to disruptive disruptive behavior. So this is a story also of pharmaceutical marketing. And why do I say that? One of the really interesting contrasts when it comes to the way that young children are pharmaceutically managed has to do with the diagnosis of ADHD as opposed to oppositional defiant disruptive disorder, and also the treatment that's used. And so ADHD stimulant medication manufacturers have carved out a market niche among largely middle class and largely white parents who are interested in the educational attainment of their children. And so middle class and white children are much more likely to be, number one, diagnosed with ADHD as opposed to another disorder, behavioral disorder, and number two, be managed with stimulants as opposed to antipsychotics. Sedating antipsychotics that, when it comes to poor children and disproportionately Black and brown children, are largely used to manage behaviors rather than to optimize educational outcome. With stimulants having been shown to improve test performance and other educational outcomes, and sedating antipsychotics not doing that, not having that effect, but sedating children in the classroom and in other places where often in underfunded schools, the staff don't have the resources to do anything else to manage their behavior.
In addition to the state that they get extra time too.
Yeah, exactly. So that's yet another story of pharmaceutical inequities and inequities in diagnosis as a result of, you know, the structures of pharmaceutical marketing and the way that we handle behavioral irregularities. We have classrooms where we expect children, particularly in underfunded schools, we expect children to sit in their seats for young children to sit in their seats for long periods of time. Recreation, you know, physical education, any other kinds of activities, those things have been cut out of the budget in public schools in many places. And so we're setting them up for a situation where they're not going to be able to comply behaviorally, and diagnoses and medications are the answer, as opposed to restructuring of the classroom, enhanced funding for physical education, arts, music, other things that enhance educational outcomes. So that's another example that fits into this story of structural discrimination. So back to EMR. So I guess the question is, what more can be done with the electronic medical record? What else is called for?
Yeah, I think so. It says, how do you see electronic health records assisting in our experience in carrying out research on social determinants of health? The available social determinants in health that are in the EMR are pretty scanty. So do you recommend something else?
So right now, I think we're seeing a real outpouring of support for integrating social needs into the EMR. What the barriers that we're running across are structural. Number one, every health center, medical center has its own EMR, its own system, and they're not compatible, and we're not well unified. So we could look to other countries for examples of how it could be otherwise. You know, the National Health Service in the UK, where you have ready access to all kinds of data. We could also look to the VA right here in the United States that's able to do things with their electronic medical record data that the rest of us aren't able to do because it's a unified system. So the fragmentation of the health record, electronic or otherwise, has a lot to do with the fragmentation of our non-system, as Dr. Lieberman was pointing out. We have a non-system.
Helena, if I could suggest something, since you're a frequent spokesperson on this topic. We recently converted to Epic. When you do a conversion, which is a major undertaking, there's the capacity for adaptation of the generic template. And if health systems can be encouraged or given a guide as to how to do that in a way that incorporates the kind of things that Myrna Weissman was asking, that may be one thing. The other thing is the two main vendors are Epic and Cerner, and you might see how to approach them directly.
Thank you for that. So in my mind, if we're going to do a structural reading here, the problems that we're facing with electronic medical record, the fact that there's so many different systems, it all depends on the vendor. Each health system is its own island, and it's very difficult to coordinate with the other systems, health systems that people go to. They're a reflection of the fragmentation of our care. We don't have a logically organized public health oriented healthcare system. And so I would want to give credit to those who are working hard on EMR interventions and say that, you know, to really make an impact, we have to examine the non-system. You know, it's kind of our problems with the EMR are a reflection of the problems with our non-system. And we really do need a public health oriented unified system, not to mention a logical way of funding healthcare that isn't completely driven by for-profit entities that aren't concerned with public health outcomes. They're concerned with shareholders. So the EMR questions still lead us back to larger structural change. And there, of course, are many steps in between. We can make some inroads by improving our EMR system, incorporating questions about social needs. That logically leads us to, well, what do we do about those social needs? And so we can do things like lobby to get Medicaid to pay for housing. There are many colleagues who are working on that problem. Where do we, if we redefine housing as a health problem, does that open up new resources? Because what we're really facing is a housing crisis. And then the EMR, once we're screening for unstable housing, leads us to the housing crisis and what to do about that. But I'd want to continually ask about the structural drivers. So our problems with EMR are going to reflect the structural drivers of this fragmentation.
I think we might need to end, but I am really delighted to just have heard all of your approach to, and especially the algorithm and sort of the different levels of the structural approach. I think that's really going to be helpful, and I plan to incorporate that into my education with the students and residents and trainees as well. So really excited to have you here. Thank you. There's just a huge audience. There's a huge number of questions that unfortunately we weren't able to get to, but I really thank you for coming.
Thank you so much, Dr. Bradford, Dr. Lieberman, and the Columbia Department of Psychiatry. It's been a pleasure.